The center established the Robert L. Biblo Memorial Lecture in 1995 in name of a center board member and remarkable healthcare leader, Robert L. Biblo. Bob was an activist and a health plan leader who headed the New York-based health insurance plan, often referred to as HIP, and earlier, the Harvard Community Health Plan. Before his untimely death in 1994 at the age of 61, he served as vice president and regional manager of the Kaiser Foundation Health Plan and its hospitals in the Kansas City area. Our Biblo lecturer for 2017 became the 44th governor of the state of Kansas in 2003. She was reelected to a second term, leaving office in April 2009 to serve in President Barack Obama's cabinet. There, as the 21st Secretary of the U.S. Department of Health and Human Services, through 2014, she worked to pass and implement the Affordable Care Act, along with managing 11 operating agencies, 90,000 employees in 50 countries around the world with a $1 trillion budget. Kathleen is one of America's foremost experts on national and global health issues, human service, and executive leadership. She was a natural, along with former Secretary of HHS Tommy Thompson, to be asked to serve as a co-chair of the Aspen Health Strategy Group, and in their inaugural work, they have chosen to take on the issue of end of life, a legacy area for the center for over 30 years. We are honored to have Kathleen share with us this evening the just-released work product of the Aspen Institute on improving care at the end of life. Ladies and gentlemen, please welcome Kathleen Sebelius.
Thank you very much. And I'm sure all of you will be pleased and relieved to know that I don't have a PowerPoint on the Affordable Care Act. It's still the law, so let's just, you can read it wherever. But it's my great pleasure to be with all of you tonight, and I was thrilled when John called and talked about this opportunity because he asked me to do a couple of things. One was to talk a little bit about the work that has been completed with the Aspen Health Strategy Group project, but also to be able to introduce to some of you a real talented leader who's just joined the Center for Practical Bioethics, Kathy Greenlee, who I've had a chance to work with since the mid-90s. It's already been a great opportunity to see a lot of friends and colleagues in this room, and I want to just start by recognizing the amazing work done over the last 3 decades by the center. I think, like too many of the treasures in this Midwestern area, you often are too humble about your assets here and about your work. It's not well known that the Center for Practical Bioethics is here, the expertise that you have, the kind of work that's done. So one of the things I'm going to urge you all to do as strong supporters of the center is stand up and speak out, because I think there are way too many people who really don't know about the asset that we have right here. It's well known really nationally and internationally, but I'm not so sure as well known as we should be in this area. I have had the privilege of knowing and working with Myra Christopher for years at the local and state level. Then I was pleased that she was willing to accept the president's invitation to be part of a convening of a national group of ethical leaders who really tackled, at our request, a number of very thorny challenges and did some amazing work, and that she continues to do great work in the pain projects. And I know John Carney, whose background and expertise in hospice, in palliative care, now with the center, comes out of good training. He worked with both the Centers for Disease Control and Prevention as well as the National Institutes of Health, and he has been an extraordinary leader in this field. And if there was any doubt about his talent, you know, we're here at the end of March Madness, and everybody's going to focus on who goes to the NBA draft, and it's always the sign of good coaches that they have these talented stars come in. Well, I would say John Carney just got in the Hall of Fame by recruiting Kathy Greenlee to come back to this area, and I'm going to talk about that a little bit in a minute. She's definitely a #1 draft pick, and it's great to have her back here. Kathy and I met when I was first insurance commissioner of Kansas, a very long time ago, and she had been in the AG's office and came to work with us in the insurance commissioner's office. She then worked with me all the way through the governor's office, which is where she really found her passion, working around seniors and aging issues, first as an ombudsman and then leading the State Department on Aging. And people assume that when I became secretary and Kathy became the assistant secretary for aging at the national level, that I brought her to Washington. Just the opposite is true. When President Barack Obama nominated Tom Daschle to be the secretary of HHS, I wrote a letter as governor of Kansas to my friend Tom Daschle saying, there's this extraordinary woman who would like to come and work with you at the Department on Aging, and her name is Kathy Greenlee, and you really need to hire her. So to my great delight, when I ended up being named by the president and confirmed by the Senate, I was brought some nominees by our team saying there are several good nominees for Assistant Secretary on Aging, because the protocol is you can't choose any of the assistants before the secretary actually gets into place. I said, no, there's one good nominee. They said, oh no, we have several. I said, listen to me very carefully. There is one good nominee, and her name is Kathy Greenlee, and that's who's going to come and be part of this. She was extraordinary in that capacity, not just in aging, but we ended up melding the aging focus with the disability community and looking at a whole host of issues that deal with aging in place, staying in place, empowering people in their communities to make their own choices, trying to focus federal dollars on amplifying state resources. And she was there in that capacity, well-known nationally, and got to be very well-known internationally because countries around the world are dealing with very similar issues. So I think there is no question that she will be a huge asset as a new vice president for the Center on Practical Bioethics and take on the aging and health policy portfolio. She is a Kansas girl who has come back home, and I'm delighted to have a chance to at least introduce her to all of you, and hopefully, as John said, you'll get a chance tomorrow to hear directly from her. But would Kathy Greenlee stand up for a moment? Yes, Kathy Greenlee, new vice president at the Center for Bioethics. So as John has mentioned, a number of you have asked tonight, what are you doing? And I am back full-time in the Midwest. It seemed like a really good time to get out of Washington. I don't know why. And among the things I was asked to do as I left the Secretary's office was to be a co-chair of a new group that the Aspen Institute was putting together, a health policy strategy group. And unlike Congress, they believe that things actually should work in a bipartisan fashion. So Tommy Thompson, who is a former Wisconsin Republican governor and a former HHS secretary, and I are the co-chairs of this group. We have 23 members, experts in healthcare, economists, patient care providers, insurers, authors. It's a pretty extraordinary group. And what we decided to do was try to tackle one big issue a year and not duplicate what is going on in the public policy arena, but hopefully amplify and add to it. I was particularly interested that we start with end-of-life care issues. I think, like many of us, I was inspired by my experience with both of my parents. My mother, who died at age 75 and was basically in a situation where I hope no one will ever be again, where she spent the last 10 weeks of her life in 3 different hospitals, being flown from place to place with way too many procedures to count, and all she really wanted to do was go home, and had way too much care and way too little control over that process. My father, who outlived her by years and just died a few years ago at age 92, ended up not coming downstairs his final day, died as he wanted to at home with hospice care, and it was just a very, very different journey. And it was so personal to participate in both of those travels, as well as to be in a position at HHS where we have a lot of the purse strings that actually helped control or not control and direct what a lot of people end up doing. So I am the lady who was accused of creating death panels, if you recall, which was our attempt actually to put a payment code in for physicians so they could have a conversation with their patients about end-of-life issues. And the pushback was so ferocious that it literally took 6 years to get that payment code. It's now part of the Medicare payment codes, but a 6-year reaction throughout the country to have that issue come to the forefront. So as John said, we have completed a project which involved a lot of discussions, some great papers, and hope to just add some ideas to this end-of-life issue to help transform care. And I would just tell you that on the Aspen Institute website, the report is available, and I would commend to you particularly the papers that were done, which are very good and solid work. But we're in a situation where we have 11,000 people a day turning 65 in this country, 11,000 a day. About 2.5 million people die each year, but about 8 million of our friends and neighbors have chronic serious illness. And unlike the mid-'60s, when Medicare was actually written and passed into law, that end-of-life situation is not a fixed period of time. It's really a process, and it's a process that often involves multiple diseases and people getting increasingly incapacitated, but very difficult to measure in days or months or sometimes even years. And the kinds of support and services that people need and want are often not only not available, but certainly not paid for by the process we have. So part of this is to use some practical principles that are well known to those of you in the room, but often not really thought about, that the voice of patients and their families should really guide the care, that health providers shouldn't provide care that isn't needed or wanted, that insurance benefits, and here we're talking mostly about Medicare because most of those deaths do occur in an older, over 65 population, should actually be updated and reflect social and coordinated care needs. Medicare is way out of date with what they pay for and what they don't pay for, and often the payment drives people to have to make decisions that they don't want to make and that they shouldn't be in. and that actually community leaders are best suited to engage care and end-of-life decisions. I think that is maybe the most important piece of this puzzle. It is not a government-driven program. It should not be a actual team leaders should include members of the health profession, but they may not be the best people to actually lead this discussion. It should be done in communities and in families. For many, this is a brand new conversation, and I think it often, on the government side, leads to accusations that care is being rationed and that somehow the government will drive inappropriate decisions. I think just the opposite may too often be true, where too much care is being delivered and that isn't really what's needed or wanted by friends and family members. So our membership has produced a report with 5 ideas, and we've also committed within this group to help drive those ideas and that conversation through various institutions and entities. I think, and you'll hear from the award winner tonight, that advanced care planning, one of the ideas which he certainly is driving, Nathan is helping to push around the country, that advanced care planning needs to be part of the normal fabric of planning for the future. It needs to be part of the conversations that people have every day and that is looked at in an employee setting. And in fact, I'll share with you, Toby Cosgrove, who is one of our members who heads the Cleveland Health Clinic, said that he intended, as part of that discussion, and I checked with him today when I was with him earlier, and he's done this, to go back and make sure that the benefits manager actually goes to everybody who works at the Cleveland clinics, not only in Cleveland but all over the country and the world, to say, we think it's an important part of your thinking about the future, the way you sign up for health insurance, the way you do anything else, that you actually execute an advanced care directive. And if you haven't done that, we'll help you do that. And we'll show you some models online. And indeed, he has carried that forward. That secondly, we need to push the redesign of Medicare for social and coordinated care benefits, not the medical benefits, which often are well compensated for, but what people really want and need often are not compensated for. Assistance with family caregiving, opportunities to really have help and support. And I think that while it's a difficult conversation to have, there is some bipartisan work in this area going on in Congress, and again, I would urge you to push that forward with your senators and legislators. That thirdly, as we move to pay for quality from the traditional fee-for-service payment, that a set of quality measures be developed in this area. Right now, it's very difficult to tell what good care is and what it's not, what should be rewarded. And I would say I think that's an ideal area for the Center for Practical Bioethics to focus on. You would be a great convener of those quality discussions. Fourth, a focus on providers really at all levels of the workforce and training on everything from palliative care to how to speak to patients who have some kind of terminal illnesses. The kind of language we use is often not well suited to having patient-centered disease and to have patient-centered care. Family members are often in a situation where they feel like they're forced into battle, and too often that terminology is what we use to confront issues around terminal illness, and that may not be the most appropriate. And lots of doctors suggest about themselves that they don't know how to talk to patients, that they've never been taught how to deal with this, and that may be a great addition to medical training. And finally, that model communities should be recognized and highlighted and can meet care designs and delivery for people with serious illnesses. Most individuals do not want to end up in either a nursing home or a hospital. They want to be in a community setting. They want to be able to have care delivered in a very different way, and that we need to find ways to do that as we age in this area. So the Center for Practical Bioethics has taken a leadership role in this area for decades. Lots of us are working hard to catch up, but this is an opportune time to really highlight and focus these conversations. Again, it's a great time to have Kathy Greenlee join this exercise in a critical role. It's a great time for John Carney's background and training to really be highlighted as people use more of hospice care, think about different ways that they can go through those last periods of their life, and we look for ways for service and support. So I want to thank you for being supporters of the Center for Practical Bioethics. I want to thank the honorary co-chairs for their leadership on this very successful fundraising dinner. I look forward to hearing the good ideas that come from tomorrow's symposium. I think nothing is more important than we engage in what are challenging and difficult, but critically important conversations for all of us, and that we share them with one another and find ways to actually get to the next chapter in this very important life journey. So thanks for having me here tonight, and thanks for the work you do.